7. So week 7, we'll be going over those chapters 46, 47. You do have diabetes did open today. Remember your clinical pediatric assessment. Let me know what you've chosen. You can attach it on the assignment in Canvas, and then you could completely repeat and re-upload things, okay? So if you want me to check it, put it on the assignment page, because I will look at it, I'll give you feedback, you can correct it, and you get better grades. It is 6% of your subjective grade, so it can affect you a lot, all right? So be careful with that. You have a discussion question that's due, and your case study, the lymphoblastic leukemia, is due also. So those are the things to be looked for. So as I decided, I'm going to do the PowerPoint. I usually do the Kahoots, but you know something? I've taken the PowerPoint, looked at it, updated it, put some things in that I like, and it's a good PowerPoint for you to go over. So make sure that I did record. Yes. I can't hear you.
Have you posted the PowerPoint yet?
Yeah, I posted it on Friday, and it's on the announcements.
Okay, I'll look again. Thank you.
And if not, you know, I'm going to right after class up to the recording, and the PowerPoint will be posted again. Okay. And the other thing I want to post for you is that week 5 matching, so you have all of those answers too. One student asked what they were, just for future reference, okay? But we know in cardiac what you needed to know, and you know your exam is done, but you can have it. So intracranial pressure, you know, in infants, there's a lot of different things that can cause those pressures to go up. Usually intraventricular bleeds, hydrocephalus, all of those things. And, you know, initially we really don't see much at all. But as it starts to increase and goes into all of those little spaces, we're going to see these certain symptoms. Now, do you see those nice little vessels in the scalp veins come popping out? Because the head's getting bigger and bigger and bigger. That's the visual that you see. Also, fontanelles sitting there at rest, not crying, and they're going to be tense, bulging, almost like a trampoline. They're getting so tense up there. You're going to see the cranial suture separating, and the eyes could go sunset, up and down, all different things could happen with that. I think the one that I noticed first, besides even seeing that, is this high-pitched cry. And there is a difference when a child has a neuro cry versus a normal cry. You could walk into a nursery and hear that one child who has something neurological going on, and they cry, and you know that they're neurological. The other thing is they have headaches. They don't feel good. They're irritable. You know, you don't feel good, you're not going to want to eat, right? So all of those things combined, we know something's going on with increased intracranial pressure. Older kids, you might see them telling you they have a headache. You know, infants can't. They're just going to show you that bulging fontanelle and that irritability. Vomiting, and it will be a lot. I mean, increased intracranial pressure is just like having a head injury. You know, it doesn't feel well, and it's going to cause you nausea and vomiting. It could get to the point of seizures. It could go on to making you drowsy and lethargic, hard to respond, okay? And you're not going to be able to move around as much, or even walking gait could be really shuffled and falling down, okay? And you'll tell them, you know, lift your right arm, and they don't know what to do. So that's that inability to follow those simple commands. Late signs of increased intracranial pressure is now almost too late, because the brain is very sensitive. It wants to have oxygen, it wants to have blood flow, and if it doesn't get it, the body, it's irreversible many, many times. So bradycardia, late sign. Initially it's tachycardia because of the pain, right? And the irritability. As we get more into that late signs, decreased motor response, sensory response, the pupils are going to be the one thing that we look at When we know increased intracranial pressure, whether it's head injury or something else, we're going to look at the pupils. And when we see they're dilated and fixed, we know that's almost irreversible brain damage going on. And then, of course, you're going to see those differences. When you see an eye that's dilated, non-responding to light, you need to tell that doctor right away if that's a new thing. That's telling you there's something going on in that brain. And it sometimes, it blows really quickly, the brain and vessels in the head. And especially in your older patients, one eye poof can all of a sudden happen even before the other symptoms. And of course, all those positionings, the cerebrate, the corticate, not as alert, more to the point of being in a coma. So we start awake, alert, we get confused, then we get disoriented, and then it gets to the point where you're lethargic, slurred speech, and it's really, at this point, it's almost to the point of a completely vegetative state, which means, you're only arousing. Sometimes we take the nipples and pinch them, and you're like, oh, that hurts. They barely move, or just slightly the elbow, the shoulders will come in. And we know there's severe brain damage at this point. Now, in the ER, we use this Glasgow Coma scale a lot. We will hear rescue calling in, child fell off second story building, Glasgow Coma scale is 6. Well, that tells us a lot of information. We know 15 is normal. Kid's awake and alert and fine. But if it's 3, that kid is already intubated, not moving, and very, very severe. 6 is still pretty bad. So it tells me, because I was a trauma nurse, primary trauma nurse, and I used to be in charge of these patients, if it is 3, 6, even 8, I'm making sure CAT scan's ready for me, the neurology doctor's there, the surgeon is there, social work, patient reps, because this child's going to come in, be extremely ill, and most likely the family to follow. So it does prepare you and tells you exactly what to picture when the kid comes into the ER. So neurological, of course, vital signs. We look at the skin, the eyes, their motor. Are they moving the right way? Of course, posturing, and are their reflexes working? These are things that we're going to be looking at. We think neuro, squeezing the hands and whatnot, and the pupils, but there's a little bit more to it. These are the sort of eyes you see, all different things. When you don't see them, they don't look normal. These are things that should be reported. Whether they're both big, dilated, or one is dilated, the sunset, sunrise, all of these things are stuff you see. We talk about the corticate, the cerebrate. It's just a moving, and it's the arching, and it basically just tells us where in the brain these injuries are coming from. So what do? We have a child coming in. They're showing signs of this decreased, sensation, and having headaches, vomiting, all of those, things. And we've ruled out, yeah, we've got something in the brain going on. Well, we're going to be doing laboratory tests. We want to make sure that the bleeding coagulopathies are not too prolonged, because the bleeding will continue to go, right? We're going to do EEG. We're going to look for seizures. We'll do a lumbar puncture, see if it's in the spinal column, and we're going to do anything that provokes seizures, like auditory, visual. These things can tell us, more about the seizures and how to treat them. We do normally a simple skull X-ray. Now, a kid comes into the ER who has fallen off of a building. We're not going to do a regular X-ray. We send them directly to CAT scan. And believe it or not, a CAT scan is a quicker X-ray than an X-ray with the machine. So unless that child can't move for whatever reason, that child will get to the CAT scan. We want to really see what's going on in the head. And then, of course, as we continue to go on, and continue it, we will do an MRI, but that's not usually the initial treatment. That is something a child has to be stable for. We have to put them in those tubes, right? We have to hook them up and watch them closely. And it is a longer procedure. So MRIs are the last thing we do. Now, how do we take care of these children? Well, if we have a child who's unconscious due to something to do with their neurological status, number one, we have to maintain an airway. Always airway, airway, airway. We want to keep that intracranial pressure reduced. And we do that in a couple ways, and we'll continue to go. And of course, treat the shock, what's going on. We're going to do level of consciousness, pupillaries, vital signs. And, when the kid first gets there, we're going to do every 5 minutes, every 10 minutes, every 50-minute vital signs. And usually by the time they get up into the intensive care, it's every hour we're doing vital signs, at least for the first 24 hours. So how do we manage these children? How do we keep their intracranial pressure down? Well, we do it by the airway. Because the airway can, through respirations and carbon dioxide, can either increase the cerebral blood flow or decrease the blood flow. So usually we want to cause CO2 retention causes vasodilatation. So we want to do the opposite if it's a bleed, right? We want to constrict it. So we're going to increase those respirations, blow off CO2, and that by itself decreases your intracranial pressure. Another thing we're going to be doing is monitoring how we're touching these children. Cluster care is for sure, and it's minimal. Suctioning only to maintain patency of an airway, because usually these comatose patients are intubated, right? So we just want to make sure that endotracheal tube is patent. Now, we can also do intracranial pressure monitoring. We can put a bolt in, we could put just a catheter in, all things. And this goes just like an arterial blood pressure. And it's right up on the monitor. And we can see what the numbers are. And we can tell if noise is bothering them, or maybe they're waking up, sedation is too light, and we can give more sedation. Whatever we have to do to keep that intracranial pressure down, we are going to do. So monitoring intracranial monitoring, again, when we're moving these children, we are repositioning. We have to make sure that that monitor stays, that it's an accurate result. So we're always zeroing it out as we say it, keeping it good. So this one here is what we call the bolt, the Richmond screw, probably most common of all of the intracranial pressures. They do it right at the bedside and we put it in, and it literally monitors that pressure in the brain. And we can see by respirations and by sedation, are we doing an adequate job? Now, when we're positioning it, well, number one, we're going to make sure that monitor is working correctly, right? But we don't want to compress the neck, which means no letting the neck go forward, no chin to the chest. We want to keep it open. So pillows, blankets. I love to take blankets, roll them up, put them underneath the neck, and that keeps that neck open. So we keep blood flowing up to the brain and back from the brain, right? We're not going to move them much. So put them on a pressure mattress so they don't get the decubituses, right? And then your neurologist, your neurosurgeon will be telling you, don't elevate that head. Usually it's 30 degrees. You don't want to put them up. You don't want to put them down. You want it just slightly elevated. And we're good. Of course, again, all the activities like suctioning, turning, positioning, this patient's not going to get a big bed bath. We're going to keep their perineal areas clean as we can, because we don't want to have decubituses down there. But we don't overdo these patients because that can harm them. These children, if possible, in the ICU will be in private rooms, because we don't want all the noise from all the other parents, activities, codes, whatever. We don't want that to be a problem. And as I said, suctioning only to maintain the patency. Now, IV fluids, I&O, intake output, it couldn't be more important. We don't want to overload these children that have increased intracranial pressure, because what's it going to do? Put more pressure in the brain. And we don't want to do that. So avoid overhydration. Now, nutrition. Does it matter if a child is comatose? They're still growing, right? They still have to have nutrition. And we have found that, okay, yes, they can have hyperalimentation and lipids, but many times if it's prolonged, they'll put them either on NG tubes or ND tubes or gastrostomy tubes and give gastric feedings because they're getting the proper nutrition that they need, right? And of course, we'll always monitor for aspiration. Their heads are low, and all the mucus, depending, we're going to be watching that closely. So, when caring for an unconscious child, an appropriate nursing intervention would to be what?
C.
It is C. Yes, the most important is the intake output and making sure that they're not fluid overload. Very good. All right, now let's get into some endocrine. So we got the basic understanding of a child with a head injury and intraventricular bleeds and how to monitor them and what to do. Now, let's go into the pituitary gland. Well, the pituitary gland is two things. One has to do with fluid balance and one has to do with growth. The anterior and posterior lobes, okay? So there could be different things that are occurring. So hyperpituitarism, the growth hormone, all right, do they grow? If they're getting enough, they're going to be growing. If they're not getting enough, they're not going to be gaining the height in the way that they should. Now, if we see a child who's not growing the way they should, and they're like 7, 8 years old, and they're really short, well, number one, I'm going to look at the family. Are they all short? Or is only the child short? Because it could be familiar, right? We want to make a kid grow taller, then they don't have the possibility to go. So we'll be looking at it. You know, we'll be measuring things like the gonadotropins, the growth hormones, the thyroid stimulating hormones, and the corticotropin deficiencies. We're going to be monitor all those things. Once we decide that that child should be taller, if the family's short, we're going to say, okay, that's what it should be. So when we talk about dwarfism, they're going to look sort of normal the first year. We can see maybe their arms or legs are shorter or some hints towards it, but all of a sudden we're going to see it get really short. They're not going to grow the height, and then we're going to realize, okay, something's going on. And they have a delayed sexual development. You know, their testicles might be smaller or their clitoris might be non-existent. These things we'll be looking at part of the assessment. So growth hormones are given in a subcutaneous injection. It is given to the point where children stop growing. And we know that it stop growing less than 1 inch a year. So if they're growing an inch a year, we'll continue it. But usually around age 14, 16 for boys, it stops growing, and we'll stop the growth hormone. So you can catch a couple inches up by giving these children these growth hormones, okay? So subcutaneous injection, and how we're going to monitor if it works. We're going to measure their height, right? Simple. We know that the hyperfunction, sometimes we call it gigantism. These children, many times they are a tumor in the pituitary gland. And these kids can become extremely tall, big hands, you know, some sort of dysmorphic figures, big jaws, tongue, ears, and they get tall very quick. Then what will we do? They're growing too much. So it's opposite. One's too little, now this one's too much. Well, we can go and look and see, is it look at the hormones, of course, but also look to see, is it a pituitary tumor? And then we'll get rid of it. Again, that's a picture of your pituitary gland, and they go up through the nose for that surgery. It's not even going opening up the cranium. Many times they'll do radiation, chemo, shrink it, and then they'll remove it. Remember though, if we take out the pituitary gland, they are going to be needing some things that they're going to be taken for life, which is cortisone and sex hormones, because your sex can also be affected by pituitary gland. So we wonder why, again, we do height and weight on children every time they go to the doctor's office. Well, we're monitoring nutrition. That's just obvious. But we're also monitoring for those other things that could happen. So as soon as we could stop these tumors from growing or give extra hormones when needed, the normaler that child will be earlier, right? So that's why we do those things. Now, one of the other things that can be happening due to the hypothalamic pituitary gland, adrenal glands, these are what we call precocious puberty. And if you look at that little boy down there, he's gone through puberty early. What would happen with a girl? They could be 6 years old, 7 years old with breasts and getting their period. So what do we do for that? Well, we can stop puberty. Can you imagine having a 7-year-old kid in your class with a beard? Can you imagine what would happen to that child? I can't. Or a little girl who's 6 or 7 years old who has boobies. Oh, the other kids are going to go nuts with that. So the best bet is to stop it and wait until the normal time that puberty should occur. And that's given by, again, another sub-Q injection called Lupron. And it works. And then we just stop it when they don't need it anymore and let them, go through puberty. Now, diabetes insipidus. All right, the first thing I want to say, and I'm going to say it twice, it has nothing to do with blood sugar. Diabetes insipidus is not diabetes, it's not blood sugars. It all has to be done with fluid balance in the body. So what happens with diabetes insipidus? Well, it has to do with a pituitary gland, and it has to do with you are urinating, drinking, and urinating, and drinking. So you can imagine all the electrolytes that could be gone. Now, when we have these children and we even stop any fluids going in, oh no, they're going to continue to put out urine output. What's interesting with infants, you give them the bottle and they drink their bottle, right? And they continue to cry because they're thirsty because of diabetes insipidus. Give them a bottle of water and they're satisfied. And then we almost know that's diabetes insipidus. So again, it's a hyposecretion of an anti-diuretic hormone. So against urinating hormone. So if you have nothing that's making you not urinate, you're going to urinate a lot. Okay, does that make sense to you? So what do we do with this? Well, sometimes it's tumors, it's traumas, infections, etc. But we need to do something that stops this anti-diuretic hormone. We want it to work better. So we give actually vasopressin. And vasopressin, it's in a nasal spray, or it's a sub-Q, and it's for life. This isn't something that's going to be cured. You're going to have it forever. And there's always a question on, you have a child with diabetes insipidus, and you start a vasopressin. How do you know that the vasopressin is now working? Well, diabetes insipidus, you're thirsty and you urinate a lot, right? You stop urinating a lot. I mean, it's as simple as that. Now, SIADH, let's look at what those words are. Oversecretion of the inappropriate and diuretic hormone. So inappropriate, too much. anti-diuretic hormone is being secreted. Anti, not urinating. You have hormones saying don't urinate. What do you see? Well, you don't urinate. What would you see in anybody? Well, they're going to blow up. They're going to be edematous. They're not going to urinate. And they're going to be full of secretions everywhere, right? They're just going to be full of it. They are anorexic. Their mouths get swollen too. They just feel horrible. So anything that has to do with fluid balance, what is your nursing function? Measure I and O, right? So whether it's diabetes insipidus or the SIADH, you are going to monitor intake, output, and daily weights, priorities right there. We want to watch that. And if you are taking too much fluid in and not urinating, you're going to restrict the fluids and you're going to put them on a low sodium diet. So very important nursing management, very simple things, but that's what we do. And again, we're going to put them on vasopressin antagonists, which again is going to let that hormone be secreted so that they can urinate. So it won't be anti-diuretic anymore. It'll allow it to go. Now, another hormone person is your thyroid, right? Thyroid, whether it's an adult, whether it's a child, it's the same thing. The only difference between thyroid hyposecretion and thyroid in children and adults is if you don't have enough thyroid hormone in children, you're not going to grow. Adults are already grown, right? But children still need to grow. Again, why are we measuring height and weight? Because of another thing, thyroid problems. Now, what are the things we monitor in the lab works? T3, T4, TSH, and a calcitonin. We're just going to make sure that they're working and if they're functioning right. Now, in juvenile hypothyroidism, many times you're born with it. And again, thyroid hormone in infants is very important. They don't have enough thyroid hormone. Cognitively, they're going to be delayed. They're not going to grow. It's a big deal. So we really need it to be replaced. And it's just what we normally give for these children. We're going to be giving that levothyroxine Synthroid, which will help. Now, as we get older and we're not increasing dosages for these children and their levels are too low, what are you going to see? Well, I told you it's cognition for children. So mental decline. And just like adults, constipation, sleepy, cold intolerance, dry skin, sparse hair is a big thing. Puffiness, and again, mental decline. Very similar to your adult symptoms, but remember, hypothyroidism also affects the growth. So without good thyroid hormones, the child's not going to grow tall the way they should. So oral hormone replacements are given as soon as we know how and why this is going on. And children, as they get older, we need to get them in charge of their care. But of course, we have to monitor through them and, around them to make sure. And again, how do we know the thyroid medicine's working? Well, they're growing, right? Their height and weight are increasing every time we see them. They're awake and they're alert. Now, goiter or a hypertrophy could be due to either the congenital with mom being on antithyroid drugs during pregnancy, or it could be due to usually an inflammation, disease or neoplasm. Now, in goiter, we need to get that goiter out. It's a hypertrophic. We don't need it. We don't need all of that. But again, now we've taken out a thyroid gland. And we've taken out the thyroid gland that gives what to the child? The thyroid hormone, which does what? Helps them grow. So these children, again, will be on lifelong thyroid replacement therapy. Now, here's the different thyroid one. This is usually girls, pre-adolescent, adolescent, and it is an autoimmune condition of the thyroid, which means you cannot take these out. This is not a surgical thing. These children must be monitored for what is missing in their blood and it needs replaced. And they could be on several different types of thyroid medicines all at once. My daughter-in-law, my son's wife has Hashimoto's, and she's like, "Oh, you know what that is?" I'm like, "Yeah, just a little bit." So anyway, as I said, these children are going to be watch them closely, and we're going to be giving them the hormones that they do need. As I said, no surgery for that one. Now, hyperthyroidism. We've had goiter, which is this big hypoplastic thyroid at birth. Well, now we have not hypothyroidism, hyperthyroidism. Too much hormone is coming out. And this also can be absolutely dangerous also. With these children, we usually see it at that pre-adolescent growth spurt, right? 12 to 14 years old. And there's two different things we can do. We can give anti-thyroid drugs, which is prolipropyl or methimazole, and that blocks the amount of thyroid hormone that's secreted. So hopefully you'll just get what they do need. Now, side effects, what we need to teach our parents, these drugs causes leukopenia. So these children are more apt for infection. They're almost like immunosuppressed. They're going to get fevers and sore throats. And these children, every time they get fever, sore throats, they need to call their physician. Is it a reaction to the medication or is it just a normal virus? And it's something a parent can't decide. The physician has to do. And that's a teaching you're going to see again. So many times they're going to do what we call a subtotal thyroidectomy, or we'll ablate it. And again, no thyroid hormone, it's gone. The thyroid has, been removed because the medicines didn't work or for whatever reason. These children, again, will be on thyroid replacement hormone for life. The one thing about it is we need to give it in the morning. Now, I know many of you say, well, I've got my thyroid levels are low. That's why I'm pudgy. So, and then the one who's skinny say, no, my thyroid is working really fast. Well, if you give that medicine, the levothyroxine, the Synthroid, give it in the morning because it actually gives them energy because they've got that hormone that's making them move around because it does speed you up a little bit, okay? So that's the way I remember give it in the morning for these parents. And one of these things, this Lugol's solution, we use that also to help with hyperthyroidism. So it's one of those things I saw a couple years back on the HESI about Lugol. So just to bring it to your attention. Now, what is the big fear? Having a thyroid and having this hyperthyroid. What's going to go on? Well, there's something called thyroid toxosis. It's called a thyroid storm. I actually was working one night in an ER, and it was actually the X-ray tech went into a thyroid storm. She just was flushed red. She said her heart was beating out of her chest. She had a fever of 104 and felt horrible. Hooked her up to the monitor, and she was like 30. She wasn't old, but she wasn't young, a child. But a child's going to act the same way. Hooked up to the monitor, and the vital signs were like what you see down there. So what do? How do we treat a thyroid toxosis or a thyroid storm? Well, number one, we got to get that heart rate down or that heart's going to go into failure. So we give what? We give a beta blocker. We're going to give a propanolol, Ilol, Olol, Ola, right? And it blocks the beats and slows it down. And of course, we're going to give the anti-thyroid drugs also to try to stop the amount of secretions coming out. So it's very medical until we can calm it down. And then if they have these treatments, these things, they are going to end up most likely getting their thyroids out. So management of hyperthyroidism. you know, let the parents know what to look for. They're going to get dizzy and headaches and chest pain and tightness, and they're going to feel that heart in their chest, and that's those thyroid storms. So they do need quiet environments, rest periods, and these children with hyperthyroidism, they do burn through calories. So they need more food, more higher caloric rich foods so that they can keep up with their nutrition. Okay. And let's go now to hyper, or not just a disorder of a parathyroid. Well, is there a difference? Parathyroid, thyroid? Yes. On the side of the thyroid is a parathyroid. Parathyroid has everything to do with calcium. So it is all about calcium. It has nothing to do with thyroid hormones. It's all about calcium. And when you talk calcium, phosphate, magnesium, these are all things that affect muscles, whether it's the heart muscles or the muscles in my arms, it doesn't matter. Too much, tetany. It's like, oh, not enough, I can't move. It's going to be very flaccid. These are things that you would see with it. Now, hyperthyroidism, what do we see with this? Well, we're going to see that dry, scaly skin, brittle nails. As I said, if it's too much or too little, you'll have those symptoms. It could be that tetany, paresthesia type seizures, things, and hypoparathyroidism. It's just your body's just really not working. Everything's down, 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 down. So what do we do? Well, we're going to start them on vitamin D therapy. And one of the reasons why the infants get D, when they're breastfed is because of that there, which is pretty interesting, isn't it? So what do we monitor with hypoparathyroidism? Calcium, muscles, heart beating, blood pressure. Makes sense, doesn't it? Also, we want to monitor their kidney function, making sure they're excreting the calcium that they need to excrete it or not excrete it too much. And of course, their vitamin D levels. We always have these children in a safe environment, so it's always safety with these two. Now, hyperparathyroidism, usually it's a tumor again, right? And we're going to be seen with high calciums. Usually this is not seen in adults. You usually see the opposite effect of these things. And we try to treat them if we can, but if not, they're going to remove it. And again, they're going to have to be monitoring their calcium levels. Now, your adrenal glands. Adrenal glands is all about steroids, cortisol, right? Aldosterone. It has to do with the how much cortisol's in your body. Now, too much, it creates all of these like a pheochromocytoma. It's like everything high, blood pressure high, heart rate high, everything high, high, high. And that causes that lightheadedness, et cetera, et cetera. So in children, when we have a child with low levels, we're going to replace the cortisol, which is a steroid, Solu-Cortef. There's Solu-Cortef, usually used with adrenal problems. Solu-Medrol is usually used in your respiratory problems. Now, cortisone and overusage, or just it has to be prolonged. We've talked about it before when we were talking about cardiac children. And it means that these children all of a sudden just swell up all over, right? What do you see with Cushing's? Usually it is prolonged steroid therapy. I actually was on a high dose steroid for 2 years because of my RA, because they didn't know what was going on. And I literally blew up like the Pillsbury Doughboy, just big swollen, everything. So what do you do if you've had prolonged steroid therapy and now you're showing the signs of Cushing syndrome? Well, you have to take them off the steroids, but you've got to do it slow. It's a very slow type of process taking them off, and usually everything will go back to the way it was. These are things that you can see with Cushing. Usually it's that big round face with those red, ruddy cheeks. It's called ruddy red cheeks. Weight gain, and they're not eating, but they're gaining the weight. And then they're puffy, fatty around the face, their trunk. You're going to see any over steroids. You're going to see poor wound healing. And you're going to be seeing bruising. Now, they look puffy everywhere, but they've got skinny arms and skinny legs. It's one of the different things about Cushing's. So if we are doing Cushing syndrome and it's due to having steroids, we're just going to take them off, and we're going to make sure that we take them off really, really slowly. So many times we have to go in and we have to do a surgical intervention on these also. So adrenal cortex has three sort of steroids: glucocorticoids, mineralocorticoids, and sex steroids. A lot of times in newborn infants, we have a decrease in sex steroids. And you know something? Babies are born with boy and girl body parts. I've seen a vagina with testicles. I've seen a penis with a vagina. So I've seen different types of body parts that shouldn't be. This here looks like testicles with a prominent clitoris, and it looks like a vagina there. But outwardly, if you look quick, looks like a boy, doesn't it? So it's one of those things that you now have to assign gender to this child. And these children don't have enough steroids, so they're going to get steroids for their life, okay? So again, this is something that you have the ambiguous genitalia. I've seen two in my lifetime, and they both were very similar to it. But again, this is something that when they're born, then you have to go through, figure out who that child is, a boy or a girl, and they're going to be on steroids for the rest of their life, okay? These, some children diagnosed at birth, they do some reconstructive surgery, but remember, they don't have all the body parts. They're not going to have children. They're not going to be able to have babies. Now, I mentioned quickly, pheochromocytoma is an adrenal tumor. Now, this is a really sneaky little tumor. And what it does is sometimes you're palpating the abdomen, doing an assessment, right? Figuring out if it's soft, tender, etc. Well, in the adrenal gland, sometimes a tumor is formed. And just that touch can release these epinephrines, these catecholamines, and sympathetic type of response, which means heart rate up, blood pressure up. And it's like brief. It's a brief elevation, and you're going to see these things. Many times the child, even adults with this one, complain of headache, dizziness, chest tightness, chest pain. It's all because their blood pressure went up and their heart rate went up. So we are going to closely monitor their blood pressure and their vital signs, okay? And then we're going to remove it when we figure out what it is. Now, diabetes. So, diabetes in children is diabetes type 1. And it's usually your younger children. They're born without enough insulin. I've seen it as young as 2 and 3 years old. They're saying the peak is around 10 to 15. What do you see with hypoglycemia? This is the one they feel jittery, sweaty, and dizzy, just like adults, right? And how do we treat type 1 diabetes? Well, these children will require insulin, and they'll need to be placed on, a restricted calorie diet that goes within the insulin that they're getting. Again, trying to maintain these children on a diet which is good for their growth. So now, sometimes they get older, and at adolescence, they become diabetic, and many of them are just overweight. They could be type 2. But once a child has diabetes type 1, they will never be a type 2. Their pancreas doesn't all of a sudden miraculously produce insulin, okay? Now, ketoacidosis. So many of you are like, I just don't really get DKA. What is it? Well, think about this. You have a pancreas that should secrete insulin that's going to go make the sugars into something the body can use, but there's no insulin. So you keep eating because you're hungry, but the body can't use the sugar, carbohydrates. It doesn't work. You can't break it down. So the body says, I'm really hungry. I really need to eat. So the body says, all right, I can't eat sugars. Let me go somewhere else. So they start eating other body sources, fats and proteins. Byproduct of these is ketones. So ketones are spilled off, and that will be seen in the urine. You can smell it on many of these children. So diabetic ketoacidosis, there's no insulin. You're not using your sugar, so your sugar level's off the roof. And you're eating the proteins and the fat because your body needs something. So what do you see? Now, these children come in. I'm going to tell you what they look like. I've seen quite a few. These are all age children. Usually they come in because they're vomiting. They are weak. They're dizzy. They're pale. You put them in a room, close the door, and you walk in behind them, and this fruity smell, which smells like a rotten peach. Put a peach in a refrigerator in a Tupperware jar. Go back a month later, pull it out, open it up. That sweet rotten hits you in the face. That is what DKA smells like. The pH, I've seen it as low as 6.8, and the child made it. Usually it's rated 7. Hopefully we catch them at 7 because it does cause severe electrolyte imbalances. Got to watch that potassium with these children, okay? And you're going to have a pH that's, not appropriate to life. So what are we going to do? Well, we're going to be doing an evaluation on children with diabetes. We're going to be doing those 8-hour things, A1Cs and sugars. Now, the hemoglobin A1C is usually above 6.5. Usually 7.5 they'll give up to with pediatrics as an okay. That would be borderline diabetic, but a little bit higher than adults. And if you look at the blood glucose, it's not 100 cut off, it's 126, only because the difference in, the way children need to eat. And a random glucose of 200 is okay. It's above that's going to say, all right, we need to cover that one. So we're going to be giving insulin. We're going to be teaching these children how to give insulin, how to monitor their blood sugar, and how to eat properly and test their urine. What are those signs of hyperglycemia? What are they going to see? What are they going to see when it's low? What should they do? I mean, they can have a little hard candy. They can drink milk. They can drink orange juice. As simple as that. I wouldn't go to eat a whole bowl of ice cream because that's too much, but just enough to get the blood sugar up so that they can eat something which has good protein in it, like a turkey sandwich is like one of the things that you always say, oh, get the kid a turkey sandwich. That works because of the protein in there. These children can go out and play sports and whatnot, but these are the children that need to eat snacks while they're playing sports because they burn off, all of their sugar, right? So they'll go hypoglycemic, and now you have insulin left in the body. So giving them snacks, checking their blood sugars before they start, checking it when they're done, very important, and they can do really good with that. Now, a nasal spray of desmopressin, DDAVP, is used for what? Anybody know? Desmopressin is used for hypopituitarism. It's used for hemophilia. We learned that last week. Vasopressin is your diabetes insipidus. So you guys got your PowerPoint for this. Again, I'm going to ask my Wednesday class, what do they want to listen to? If they want to have the Cahoots, I'll give you the same recordings that you can have both of them again. So any questions? I don't see you next week. So I will be letting you know, you go to my YouTube channel, there is a week 8, pick anyone you want. And I'm going to be sending you, I have another matching, because again, it's another one of those subjects that has a lot specific to children. So I'll send you that so that you have that as you're studying along. And I'll get those questions to you by Friday for those who cannot make another class.
I had one question regarding the NCLEX questions.
Sure.
How are those being graded? Like I'm doing like 75 and I'll get 70 out of 75 and still not get a 50.
You know, you did do more than that, and I just took a percentage. I could make it a 50, Gregory.
Okay, I just wondered,
I know
couldn't remember which, I know I asked the question before. I couldn't remember if it was in maternity or this class.
Both you and
Okay.
Ashley both do more than, which is great because the more you do, the better it is for you. So I do see that. So yeah, I can give you credit for doing more.
Okay.
Not an unfair question.
Thank you.
You're very welcome.
Is the makeup class that we signed up for, like if we were doing Wednesday, is that this Wednesday or next Wednesday?
Next Wednesday, week
Okay,
8 Wednesday.
perfect.